Working at SCRC as a nurse practitioner. Thanks for joining today's webinar. So we're just going to jump right into what is fertility. Fertility can be defined as an individual's ability to conceive and carry a pregnancy. And then on the other side, there's infertility, which is the inability to conceive naturally. So we define that as under 35 years of age old trying to conceive for a year, or 35 years and older trying to conceive for 6 months. And treatment is based on our evaluation. We would perform a medical history review, physical exams. We do diagnostic testings, which include blood tests with hormone levels, immune panel, and depending on what else the patient needs. So here is you see in the chart, we evaluate your ovarian reserve by doing the AMH, FSH, and E2. And the higher AMH level can indicate a larger ovarian reserve, which means the number of eggs available. So the lower level can indicate diminished reserve. So the most common reason ovarian reserve declines is age. And one of the procedures I perform is a hysterosonogram and HSS test, and it's done in patients to evaluate the uterine cavity. And typically we do that before a transfer to make sure that there are no polyps or anything in the uterus that can prevent a pregnancy from occurring. And we do that by injecting saline into the uterine cavity to look inside of the uterus. We also do male testing, which includes a semen analysis and also necessary blood workup. And we have an amazing lab here who performs this test. And in the semen analysis, we look for the volume, concentration, motility, morphology. And as you see, the studies indicate that 25% of the infertility is primarily male factor, whereas 40 to 60% is affected by sperm. And IUI is also one of the fertility treatments that I perform. And it's where, the washed and concentrated sperm is directly placed into the woman's uterus during an ovulation to increase the chances of fertilization. And so there are good candidates and less favorable candidates. And let's start with the good possible candidates. So couples with mild male infertility, such as maybe a low sperm count or motility, or using a donor sperm, or women who don't ovulate regularly, mild to moderate endometriosis, uterine or cervical abnormalities. So the less favorable is if there's a severe male factor, severe endometriosis, if the tubes are blocked or damaged, of course, the diminished ovarian reserve. And so these patients have a better chance with IVF. Next. And it's so important to have a good support system during this process, a compassionate network of family or friends and healthcare professionals that could benefit you through this journey, and maybe someone who's also going through it or has been through a similar journey, because they're going to help you through with emotional support. It's going to reduce your stress level, give you a positive mindset. So creating that community is very important to get you through the process. I understand the mental, emotional, and physical challenges that this can bring onto the patient. So I am committed, and the team is committed to supporting our patients through every step of the process. And every patient's journey is unique. So we do offer an individualized plan of care, and I'll be happy to have a consultation and explore how we can best support you on your path. If you have any questions, I'll be happy to answer them. If you want a more personal one-on-one, then we can schedule a consultation. Thank you.
Mariam, that was great. Thank you very much. I wanted to just mention about AMH hormone level. to some people used to doing things that are dependent upon menstrual cycle called FSH.
Right. Can't hear. Can't hear. Sorry, Dr. Surrey, I think
I'm sorry?
I couldn't hear you. I'm sorry.
The FSH is dependent upon your own estrogen level. So you have to do
Correct.
it in part of the cycle. The AMH
Correct.
don't have to be at a certain phase of your cycle. You can do it anytime. of your cycle.
Anytime, right.
You could
That's
be on
correct.
to do it as well. It's a much better test. So I'm glad that you mentioned that, as well as an image. Ultrasounds are terrific ways of looking at the reproductive system. And one of the nice things that it will tell us about is just that. You will tell us about your ovarian reserve along with the AMH test. And those are things that, but you know, there are people who are young and have diminished reserve, and people who are older, good ovarian reserve. So
That's true.
is a combination of the number of eggs that you produce, as well as their genetic content. We know that as human beings, the produce changes and becomes less normal, which is one of the primary reasons why fertility declines as we age and miscarriage rates increase with age. So there are a lot of different things that we have to treat fertility issues. Is that your fertility can be preserved for the future without fertilizing eggs. You can preserve unfertilized eggs, which is very effective. Mariam mentioned she is good at performing intrauterine inseminations, which is taking a specimen of washed sperm, placing it inside the uterus at the time of ovulation based upon an ultrasound. But you know, this is natural fertility. So in order for an intrauterine insemination to produce a pregnancy, the sperm and the egg have to meet in the fallopian tube, have to fertilize and create a normal embryo. So when you do an intrauterine insemination, you don't really know about that. And indications for that, not advanced maternal age. They're really limited to things like problems with sperm movement or problems with cervical stenosis or closure of the cervix that would not allow sperm by having intercourse. So, you know, there are different reasons why this could be helpful. Feel that age, one of the indications for this, and it really isn't. As we've discussed, age, but you won't know about this process. So it is a useful treatment, but not for everybody. So when we look at things that we call assisted reproductive technologies, which are things like in vitro fertilization, you have to have a normal architecture or anatomy to start with, as evidenced by an ultrasound and a hormone test. The ovaries are then stimulated with natural releasing factors. So you're making your own eggs. Your eggs are making your own hormones. So it's nothing that's foreign to your system. And the reason why to do this is because, as we know, not all the eggs you produce are going to create a normal pregnancy. Or there's a better chance of finding something that will. So during the stimulation, we need to see you from time to time, and that would consist of monitoring ultrasounds and hormone levels. Your eggs are ready to be asked. Next. What it looks like. The ultrasound shows us what are called follicle developments, which are the dark circles that we see. This particular person has a lot of them. Each ovary probably has 8 to 10 follicles, which is a very high response. This is actually a little unusual. We see this not infrequently with even our older patients with stimulation. The eggs are aspirated by ultrasound, so there are no incisions and surgeries done per se, and they're aspirated with a needle guide. And you're given a sedation intravenously, so you don't have a general anesthetic, but you're comfortable during process, which really only takes about 20-30 minutes in total. Next. Once your egg is there, the sperm individually is injected into each egg. This is called intracytoplasmic sperm injection. And that's shown on this little video here. And we know then that the egg and the sperm have met and should cell division as a result of meeting. And that cell division is something that we can see. And a system that's somewhat unique to our place here that involves watching the embryo divide, so we know if it divides normally or not. Next. Embryo development is key to this process of fertility. This embryo, you can see what is called trophectoderm. Those are the cells that are being aspirated there, that are outside of the inner cell mass, but very representative of the genetics of the embryo. So this person's embryo is having what's called trophectoderm, biopsied and extracted. That's, again, outside of the inner cell mass. So it will not have any adverse effect upon the embryo, but it will be very accurate representation and what we call the chromosomal analysis of each embryo. This can only be performed on embryos on around 5 to 6 days on average that have what's called a blastocyst. It is the blastocyst that can cause a pregnancy. Embryos that do not reach that stage of development will not cause a normal pregnancy. So that's why people ask, well, do you do day 3 transfers? And the answer is no, we usually don't, because we don't then know. And part of this process and the advantages of the diagnostic aspect of this process are lost if you don't know what the embryo is doing. Next. Next. Here is the way we see embryo develop. This is an incubation video. It's divided to about 16, now 32 cells, now 64 cells, and now called a blastocyst of over 100 cells. And it is at this stage of development that pregnancies would normally occur. As a result of an embryo of this stage implanting in the uterus. So the technology of what we call assisted reproduction basically mimics what so our technology that this process is something that we're very proud of. It's not something that is done in many places, and it's something that enables us to not only diagnose normal or abnormal, but by having the embryos in a closed system that is not exposed to the environment, we get better embryo development. So we talked briefly about fertility preservation, and it works very, very well. When we look back on what's happened with our survival rate is over 90%. And there have been over 6,000 babies born at our center with no increase in maternal, fetal complication, or increase in abnormal. Next, please. So I wanted to let you know that there are 4 see you, and we would all be happy to see you if you'd like. And any seen everybody tonight, or have spoken to you anyway. And I wanted to see if anybody has any questions while Mariam and I. So let's